Good morning to all of you, and welcome to the webinar on Management of Lymphedema, organized by Society for Health Research and Innovation. Before moving to the webinar, I would like to remind you on the housekeeping rules. The webinar link will be available from 9 to 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for the CPD points, and the CPD points are strictly adhered to the NC-CPD guidelines. This is to improve and maintain the standards of the CPD programs conducted by Society for Health Research and Innovation. We appreciate strict adherence of the CPD regulations and your kind compliance. Question time would be at the end of the webinar. If you have a question, please type it into the chat function. Please change your chat settings to all panelists and attendees so your question can be answered. If you have very specific questions about your situation, please email us on office313@gmail.com. So without further ado, let me introduce the speaker for today's webinar, Dr. Pragaash Shanmuganathan, Consultant Plastic and Reconstructive Surgeon at Srimavo Bandaranayake Specialized Children's Hospital. Dr. Pragaash has graduated from Faculty of Medicine, University of Peradeniya, and obtained his MD surgery with board certification in Plastic and Reconstructive Surgery from Postgraduate Institute of Medicine, University of Colombo. Following that, he has obtained several qualifications and served in Srimavo Bandaranayake Hospital, Peradeniya, Lady Ridgeway Hospital, and National Hospital, Kandy as a consultant plastic and reconstructive surgeon. So I would now cordially invite Pragaash Shanmuganathan to commence the session. Over to you, sir.
Hi, good morning. So we'll start on a topic today, that's management of lymphedema. We all know that many people get scared of lymphedema. Clinicians are worried, how can we manage this? And then when the patient walks in, you get stressed out, what solution you give? So today I'm going to talk about some basic facts, so that will help you to assess and then advise and maybe manage a lymphedema in a setting that you work, probably in your private practice or in a clinic. So we'll get into some basic facts first. So we have to know what is lymphedema. So we know what is edema. And the lymphedema is a swelling of the part of the body. It can be a limb, it can be a neck, or even it can happen in the internal organs. It's because of accumulation of lymph in the body. In the lymph is a protein-rich fluid, and that accumulates in the space between the vessels. That is the interstitial space. And then normally the fluid in the interstitial space is drained by the lymphatics, because here the lymphatics are abnormal or not functioning. So these fluids gets accumulated in this place. So this lymph that accumulated in this space on a long period, it caused some repeated cycle of inflammation, fat deposition, and then it can lead to fibrosis. So during the late stages, the one we normally see. So we rarely see the patient coming early. So lymph, so when you look at the circulatory system, you know that you have an arterial system. So the oxygenated blood is carried to the tissues, and then there's diffusion occurs at the capillary level. And whatever the fluid that comes, most of the fluid will return to the heart by the venous circulation. That some of the fluid that is in the interstitium will be carried by the lymphatic fluids. So here, that fluid that goes through the lymphatic system is called the lymph. And then normally, when you look at that fluid, about 20 liters of the fluid is filtered at the capillary level. And then about 2 to 4 liters of fluid is carried by the lymphatic system, rest by the venous system. So we have to know why the lymphedema happens. So normally there is disturbance of the flow of the lymphatics. This can be congenital anomalies in the lymphatic system, that we call it congenital, or maybe the other term is the primary lymphedema. The lymphatic system are not properly developed, they are hypoplastic, or they are not present at all. Or the lymphedema can happen because of some secondary lesions that we call secondary lymphedema. the commonest causes around the world is the filariasis. This elephantiasis we all used to see so many years ago. Now the condition is a little less. And if you look at the developed countries, the commonest reason for the lymphedema, the secondary lymphedema, is the cancer surgeries, mainly the lymph node removal or the treatment for the cancer like radiotherapy. So primary lymphedema, these patients come little rarely. So there are three types. One is congenital, that when the child is born, you can see the lymph is swollen. And there's a second type is called lymphedema precox. That is also they have the problem in the body that the lymphedema manifests during the second 2 years to 35 years. The third type is the lymphedema tarda. That happens, the patient presents after 35 years. So these are primary lymphedema. These are some problems in the lymphatic system development. Normally, the cause is some genetic mutation in the lymphatic system that leads to abnormal development or absent in the lymphatic pathways. So next, we'll go to the causes of secondary lymphedema. This is the most common cause of the lymphedema you get into your clinical practice. The commonest causes in the world, I said, is the infections, the filariasis. And then in the developed world, the commonest cause is the surgery, most commonly the breast cancer surgery, mastectomy, and then you do the lymph node resection, or you do a sentinel node biopsy. Some gynecological malignancy, you do pelvic node dissection. And then for the melanoma, you got inguinal lymph node dissection. So for this reason, they get the secondary lymphedema. And also you can get lymphedema due to radiotherapy to a region, especially for the axilla and to the groin. And then sometimes the repeated cellulitis can damage these lymphatic vessels, that can lead to a lymphedema. And patients who are obese, even without having not other issues, even if they are obese, the obesity can cause some obstruction of the lymphatic vessels, and over time they can develop a lymphedema. And malignancy is also, even primary and secondary malignancy affecting the lymphatic system can lead to secondary lymphedema. So there are so many causes you can talk about the secondary lymphedema, and then it's important for us to identify which condition is causing. So the pathophysiology, what happens when there is a impaired lymphatic drainage, either because of the absent lymphatics or the blocked lymphatics, when this lymphatic fluid get accumulated, and there is a cycle of inflammation, and then the inflammation can lead to fibrosis, and then also the abnormal lymphatic flow can lead to abnormal adipose tissue deposition. So this causes increased sites in that lymph. So what happens when there is a lymphatic disruption? The lipid cycle is disturbed, because most of the fluid that is secreted or filtered through the capillary is mainly lipids. And then there is an increased lipid storage in the extremity. And these lipids are not normal lipids, they are abnormal lipids. They undergo some remodeling, and that leads to fibrosis and inflammation. Even a person who is not very obese, who is like a normal BMI, if their lymphatic system is obstructed, they can develop fat accumulation. You don't have to be obese. Classification wise, this is mainly theoretical. You can classify, it's called the Bruner's classification. We use it for the research purposes. So there's a stage 0. When there's a stage 0, the lymphatic, we say it is subclinical. So there's a problem in the lymphatic system. Either there's a lymph nodes are removed, or radiotherapy given, or some surgery happened on this region, but the patient does not elicit or show any lymphedema. So this is called subclinical or stage 0. Stage 1 is when there is a swelling, but the swelling settles when the limb is elevated. Stage 2 is the limb is elevated, it reduces slightly, and then there is it does not cause pitting edema. So it's a little bit more than the stage 1. Stage 3 is the very advanced stage. We see the papillomas, and then fibrosis, thickened skin, and some ulceration. That's stage 3. By the time patient comes to stage 3, it's late stage. So the lymphedema, how it presents, I said about this classification, subclinical to stage 3. More commonly, they can come up with the chronic illness. They say this limb is swollen, it's not going down. I'm doing all the bandaging, massaging, it's not going down. Sometimes some people can say the shoes are not fitting properly. The sizes are different in both legs or the foot. Or sometimes they say they wear the bangles that can be tighter, or even for their dress that can be a problem. And some people on the later stages, they have problems with finding clothes for them because one hand is smaller, other one is bigger, so they have to kind of try to get proper clothing. Sometimes patient can develop complication and present, for example, cellulitis. Our settings, we get more patients coming with cellulitis, saying that fever and then swelling and redness. But when you actually look at it, the patient has lymphedema to start with. Then now it comes to us as clinicians. When the patient presents to us, how are we going to deal with the patient? And then we have to at least give some advice, even if we can't treat it. So it starts with a detailed history. You have to identify it's a primary lymphedema or secondary. If it's a secondary, then we have to find out if it's whether it's a malignancy or it's a treatment for malignancy, or there's an infection, or it's like filariasis or even cellulitis. So we have to identify the cause, and then you examine the limb. So I'll show you how to examine the limb later on. And then we do some photograph for the initial evaluation, and also we have to check whether our treatment is working or not. And then at the same time, we have to exclude some coexisting conditions, especially varicose veins and DVT. So for this, we need to do a scan, for example, duplex scan. So one of the tests that we call the test of choice, or the investigation of choice for assessment of lymphedema, is called ICG lymphoangiography. What happens here is you have that dye, we call it indocyanogreen dye. We inject into the web space on the subdermal level, and then with some special camera, that is the infrared camera, we look through the infrared camera, then you can see this, the indocyanin green is going through the lymphatics, and depending on the type of the damage to your lymphatic system, you can see different types of the lymph flow. So this is important for the surgeon, especially for the plastic surgeons or whoever do microsurgery to reconstruct the lymphatics. So this is important to identify which type of lymph flow the patient has. So normally there are 4 types we describe. The normal pattern is called linear pattern. So I show it later on also. So when you look at the picture on the lower right, the first one, linear. So you see some white lines going on. The second one, you see the white lines and also some spreading around the tissues. And then third and fourth, the stardust and diffuse are very late stages. So this is going to be a video. So I show you how to do the ICG lymphography. This is important to know when the patient comes to you, and then advise what investigation to do, and then how to identify what type of lymphatic abnormality the patient has. Yeah. So first here we are showing the normal lymphatic in a patient. You see, they can see the white color lines going on. So that is the lymphatic, in ICG green, that is flowing through the lymphatics. So this is a normal limb. So, and then you see a lymph node. Next, we'll see a patient who has lymphedema after breast cancer treatment. So here that fluid is injected, and then you see that's white lines going on. So that is the linear pattern. And you go proximally, can you see that is kind of diffuse? So that is stardust pattern. So this patient comes a little later, but on the distal end, there are good linear lymphatics. So that's how we investigate for lymphedema. It can be done in the bedside also. You don't have to send the patient to any lab or anything. We just need to have that device with us. So let's see if the lymphedema is curable. So you can't, it's like you are getting a diabetes or hypertension. So you can't cure the disease, but you can control the disease and live a normal life. So with treatment, what we are trying to achieve is make the patients look better, to try to get the limb size normal as possible and give a good quality of life, and also prevent any infections. So patient comes with like very swollen legs, and then we are like worried whether it is whether can you do anything for that. So look at these pictures. It's never too late to treat in a motivated patient. Even with conservative management, without surgery, you can come from this left to right. So you need a motivated patient and a good team to treat these patients. So let's talk about the management. So what normally we all do is we manage this patient conservatively, and then we evaluate the patient, and then for each patient we just draw a treatment plan. So treatment plan is different depending on that stage of the disease. So when the patient comes early or when the patient comes later, then we devise the treatment differently. So here this is a video. So this is a video that show how you examine the patient and then assess. So normally what we do is mark from a bony prominence. There's a lateral malleolus, and then every 5 or 6 or 4 centimeter intervals you mark, and then you measure the circumference of the limb. So by doing this, what you are trying to achieve is you can, with the treatment, you can see how much the swelling is reducing, and also it will encourage the patient to get into the treatment plan. Next slide, please. And also it helps the patient play this video. Patients to motivated, and then it will help the patient to work with us. So when you see assess the patient, it's important that you look at the web spaces, you see if there's any fungal infection. And then if the patient has dry skin, you apply a moisturizer. Here you see that you are applying a moisturizer and massaging the limb. So it's important to keep that skin moist and soft rather than dry and crackles. So there are different techniques to do massaging for the limbs. Mainly the physiotherapists will do it. So our job is to refer this patient to the physiotherapist. So make sure the nails are properly trimmed, and then the patient inspect the leg regularly to see any fungal infection or any cellulitis. So let's see if the lymphedema can be managed without the operation. So normally, whoever the patient comes, all the patients are initially treated conservatively for 6 weeks. And then this will involve a strict bed rest with elevation of the limb. And then we'll do some compressive bandages. I show you how to do a 4-layer compression later on. And then we do a skin care, apply some moisturizing cream. You can use Vaseline, any oils, olive oils, or gingerly oil. And then you do a physiotherapy. So it can be done by the patient himself, relatives, or the physiotherapist. So normally the lymphedema kit, you need to have different types of bandages. You need to have padding, gray bandage, stockinette. So here is a video. So this is a lymphedema kit. So normally, I just walk through. So you need to have different types of bandages, stockinettes, and then foam bandages, gray bandages. Then you moisturize the skin, use any antifungal dusting powder to make sure that there's no fungal infection. Then you start wrapping from your fingers the stockinette well. And then you start bandaging from the fingers. This one is the easiest technique. Even you can do it in your private practice. If you are interested to manage the lymphedema patient, you start with your fingers. Can you see that bandaging? distal end and come proximally. Let's rapidly fix. This is a normal gray bandage, so this is so this needs a little bit of a training. So if you do like on a couple of patients, it's easy to do. Then you can start your conservative lymphedema clinic in your dental practice if you are interested, and then refer the patient to surgeons depending on the issues that comes later on. So see that the hand is wrapped, so that's how we do the hand, and then you have to work from distal to proximal. Put back. So this is the 4-layered bandaging technique. You start with the cabinet, then you form dressing. So form is that we have the soft roll. Sometimes we have this cotton. So apply the foam bandage. So this is your second layer. So each turn you are half overlapping your bandage. You start distally and then you're going proximally. This can be done by the caregiver or the relative also. You don't have to ask the patient to come to a clinic or go to the physiotherapy every time. Normally the patients are asked to wear this for so this is the third layer. Crisscross. So you can see it in how to do this crisscross bandage. So it's important to keep the same tension when you put the gray bandage. Not tightly or not too loosely. So the same type of tension. Here you can see that crisscrossing. So you're going distal and distal like a crisscross. So this is called the crisscross technique. So this you do it on the third layer. So it's again showing the crisscross bandage. So we started with a 4-inch gray bandage. Now we are putting on top the 4th layer, that is the 6-inch gray bandage. So you need to have different types of gray bandages. This 4-layer bandage. Very effective way of compression. As kind of a mild disease, you can try compression garments that you might have seen. That does not give pressure. So you see that crisscross. So it starts from distal and then work proximally. Next slide, please. Let's go to the next slide. Yeah, so those are the bandaging technique. Any one of you can do it. We are more welcome if you want to learn from us or any plastic surgeon, go and learn. It's very important to know and then get the patient motivated so they will be grateful to you. So let's talk about the surgery. So this comes next stage when you see seeing the patient and then this bandaging, and then you have to know what to do next. So surgically, what we say is there are two different types of procedures. One is physiological procedures. Second one is a debulking procedures. So till recently, we all been knowing debulking procedures, like you are removing the tissues. But recently, within last few years, there are some physiological procedures has been popularized in the world. So these are we call it super microsurgical anastomosis. So these vessels are so tiny. So you need to have some additional training. So to anastomose the lymphatic vessel or lymphatic vessel to a venule or to another lymphatic vessel. So we can do either lymphatico-venous anastomosis. That means you divert the blocked lymphatic system into the veins. So the lymphatic fluid is going to drain into the venous system. So, or you can do a vascularized lymph node transfer. So you take a lymph node with the vessels attached, and then you do a microvascular anastomosis in a region. So these lymph nodes will act as a sponge, absorbing the fluid that is accumulated in that region. So these are the physiological procedures. We have currently started doing it in Sri Lanka also. So mainly we do it in the national hospital at the moment. We're trying to get it done in the other hospital where the plastic surgeons are also working. So debulking procedures, what happens is you remove the excess tissue, either by you cut it off or you do some liposuction and remove the fat tissues. So this is a lymphatico-venous anastomosis in a patient. So these vessels are so tiny, like less than a millimeter, 0.8 millimeter. So you connect that lymphatic vessel into a venule in a subcutaneous tissue. This is done under local anesthesia. You don't have to do a general anesthesia. But you have to do a few lymphatico-venous anastomosis on a limb. So if you look at this patient, we might do one on the dorsum of the foot, one on the distal foot, mid-calf level and proximal calf level. So we have to do few. So this is helpful in the early stages only. And then next type is that vascularized lymph node transfer. So this also can be combined with that lymphatico-venous anastomosis, and then it will give better results. So debulking, when the patient is in the advanced stage, where you see that you can't do a lymphatico-venous anastomosis or lymph node vascularized lymph node transfer, then what we have to do is we can do a debulking procedures. So there are different types of debulking procedures described. It depends on the type of that swelling the patient has. Sometimes we can excise a wedge of tissue, or we can just remove the subcutaneous tissue only. Sometimes we can remove everything and skin graft the whole limb. So it depends on the patient's condition. So if the patient's limb is swollen, but the patient doesn't want to get removed, like surgically, you can do a procedure called liposuction. So you must have heard that people these days do liposuction for everywhere, for tummy, to the back, chin, arms, thighs. So the same technique we can use it for lymphedema patient also. So not a cosmetic, it's just a cosmetic treatment for this patient. So you remove the excess fat by liposuction, but saying that this patient needs to wear the compression garments the rest of the life. So this is not a definitive treatment, just limb reduction. So coming to closer to the end of this talk, so I'll say some do and don'ts in the lymphedema, which you might have to tell your patients. Let's talk about some things that the patient can do. So first, you have to keep the skin meticulously clean, because these patients are at risk of getting cellulitis frequently. So they have to check for any cracks, any rashes, or any fungal infection regularly. They should use a moisturizing soap. And even when they are taking a shower or bath, they should use the moisturizing solution or moisturizing soap. And then you don't rub the skin, just mop and dry the skin with a soft towel. And then when the patient not in mobile or maybe resting, try to keep the limb elevated as much as possible. And then the patient needs to wear any compression garments or the 4-layered bandaging or compression stockings throughout the day. They can remove it for 1 hour when they want to have a shower or bath. And then they need to exercise as much as possible. And then it needs to be discussed with the physiotherapist. They will advise how to do exercise and massaging. And if the patient gets any signs of any infection or any symptoms of pain, they should get early treatment, because they are at very high risk of getting cellulitis. So next talk, what are the things that they should not do. And we should advise not for them, or maybe even Buddhist people who wants to go to the temples. So, and then when they walk on the hot sun, so advise not to walk barefoot. So we have to also tell them, advise any compressive like watches or rings, so that with the swelling, the distal end of the limb can get a little bit ischemic. So make sure that they don't wear any tight bangles or rings. And then the nails should be cut very short and kept clean. And then also we advise them to tell that doctor or nurse not to do any blood drawing, cannulation, blood pressure measurements on the same limb. And then they should not do any tattoos, especially, or no piercing or tattoos. And then also advise them lose some weight, because obesity can make lymphedema worse. And then we tell them avoid hot showers. Ask them to get cold showers much as possible, because with the hot showers, the lymphatic vessels get dilated, there's a more fluid gets accumulated and can make the lymphedema worse. So tell them get some cold showers. So that comes to the end of the talk. So to summarize, so we all get to see lymphedema patients frequently. Most of them are neglected, and then we also don't know where to send them, what treatment they can get. So it's important to know whether they are primary or secondary. And then if the secondary, find out what are the cause that's causing the lymphedema, and then try to prevent infections. For that, you have to advise on how to be clean and seek a treatment when they get cellulitis. And then the treatment, what are the treatment can be offered to this patient, and then you have to, depending on the stage the patient in. So sometimes we see that patient who has undergone mastectomy developing lymphedema, they've been tried with conservative management for a long period. So it's important for them to know that there are some physiological procedures we can do to make it better, and maybe stop progression of the disease. And then when the patient is in the late stage, and then we know what are the excision or what can be offered to this patient. And then more importantly, we have to tell them what are the things that should be done and what should not be done. So that's the end. Thank you. So do we have time to answer some questions here?
Thank you very much, sir, for the comprehensive lecture. We have several questions sent to the chat box, sir. One is stockings therapy contraindicated in lymphedema with underlying occlusive arterial disease? And what are the other contraindications for the stockings therapy?
So stockings, we hardly see any patient with occlusive arterial disease with lymphedema. But if the patient has occlusive arterial disease, that compression garment is contraindicated. You can't do a compression garment to a patient who has occlusive arterial disease unless they are revascularized by the vascular surgeon. So that's the contraindication. Other contraindications for bandaging is that cellulitis, active cellulitis, you should not put compressive garments. And then if the patient has a malignancy, like a proximal malignancy on the limb, then that's also contraindicated unless that malignancy has been treated. And then sometimes a patient who has a very friable skin, they have blisters, those patients, it maybe is difficult to put the compression garments. So those are some of the commonest contraindications for compression garments.
Thank you, sir. So with this, we conclude the webinar for today. I would like to thank Dr. Pragaash Shanmuganathan, consultant plastic and reconstructive surgeon, for conducting an excellent lecture and spending his valuable time with us today. And thanks to all of you for joining today. And I invite you to join with us for the next webinar as well. Link for the certificate is available in the chat box. Please fill the Google form. We will be providing the certificate within the day for the first 100 participants who fill the form, and others will receive it in the due course. Thanks again for joining with us today, and have a good day. Thank you.
Thank you.